Hello, everybody. Good afternoon to one and all. Thank you so much, ma'am, for the amazing introduction, and thank you so much to Bhushan sir and Vikas Kakkar sir for providing me with this opportunity to be presenting on this forum. I'm a maxillofacial surgeon with a formal training in head and neck surgical oncology, and now I'm working here at Weaker Hospital. So basically, I'll be talking about the mandible, and it's a very small bone, but it's a very significant bone. It's a very strong bone. I'll be covering more so about the anatomy for the information of all the postgraduates present here. However, I'll also be dealing with how you can clinically give importance to the bone and how it is important in your surgical practice, and how I personally believe that me as a maxillofacial surgeon and you guys as ENT surgeons, we can collaborate and how we can work together, because this team effort is always, which is very amazing. It works wonders, and that I've seen from my personal experience. So with the mandible, you can see it's basically having an endochondral and intramembranous growth in the embryology. The endochondral is from the cartilage that happens over the condyle and the parasymphysial region, and the other part of the mandible is intramembranous growth. It's a horseshoe-shaped bone, and the basic just briefly I'll tell you about it. The condylar process, the coronoid, and this is the ramus. Now, when we talk about the central incisors in the mandible, the lower central incisors, that is the mid-symphysial region. That is the symphysis. From the central incisors till the mental foramen is the parasymphysis, and from the mental foramen till the angle, basically the attachment of the anterior attachment of the masseter muscle is your body. Then you come to the ramus, and then you come to the coronoid and the condyle. Now, there's this groove which is known as the mylohyoid groove. Here the mylohyoid muscle attaches. Coming from both the sides, it's a fan-shaped muscle, it comes down. And anteriorly we have the genial tubercles, from where the geniohyoid and the genioglossus muscle, they pass out. Between this genioglossus and geniohyoid and the mylohyoid muscle is where you will find the duct for the sublingual glands, which will come out through the floor of the mouth. Supplied by inferior alveolar artery, the nerve supply is inferior alveolar nerve, mental nerve, and the incisive nerve, and then you have the lingual nerve. So the muscle attachments. Here you can see this is one of the strongest muscles of our body. This is the masseter. It's weighing about 200 pounds, and this has the power to even pull a baby elephant. So that's the masseter. Then we have over the condylar head, in the pterygoid fovea, you have the attachment of the lateral pterygoid muscle, which helps in the movement of the condyle. On the coronoid process, you have the temporalis muscle, and here you have the buccinator muscle over the molar region. Coming down, you have the some attachment of platysma muscle. And finally, the masseter is on the buccal side. Something to counter it on the medial side, inner side, is the medial pterygoid. And between them, you will have the pterygomastoid sling. Anteriorly, you have the mentalis muscle here. Now, this was basic anatomy. Now, sometimes we do cases under local anesthesia. We don't always need to give general anesthesia for all of the cases. In those cases, you need to know about the various nerve blocks that you can give. Those are like the inferior alveolar nerve block. There are approximately 23 techniques which have been reported how to give an inferior alveolar nerve block. But the most common we give is from the opposite side premolars and going into the pterygomandibular raphe and going inserting along the lingula, where the inferior alveolar nerve enters the mandible. Then we have the lingual nerve block. These are all specific different nerve blocks which are there. Then we have the mental nerve block, which is between the two lower premolars. You go into the depth of the vestibule, aspirate, inject. And then we have the long buccal nerve, you can block the long buccal nerve. For if you're operating near the angle of the mandible or posterior body. Now coming to the approaches to the mandible. Approaches to the mandible could be the most, the common scarless approach is intraoral approach, where you give a vestibular incision and then you go down to the mandible. Besides that, you have the submandibular approach, you have the retromandibular approach, the preauricular, and the lip split. Preauricular, basically you need to give when you're operating, you're going near the TMJ or the condylar head, or more so the condylar neck as well. When you're going from the condylar neck downwards into the ramus and the angle, you can give a retromandibular. For the submandibular gland or the lower submandibular pathologies, you could give a submandibular incision. Or for a very comminuted fracture of the lower border of the mandible, you can give a submandibular incision. And lip split incision, you can communicate with the neck dissection incision for your mandibulotomies or your mandibulectomies. Now coming on to the surgical and the applied aspect of mandible per se, trauma most commonly. We have a lot of facial fractures which are happening nowadays because people refrain from using helmets despite strict rules. So the most common area which is fractured is the condyle, the angle, these two areas. And the mandibular fractures are really common in today's time. So as per there were these principles given by a person called Champy. He gave two principles. He said the upper layer, when it is impacted, the upper layer would have a zone of tension and the lower layer would have a zone of compression. So as a result, and in the anterior region, there would be talking forces also because of the action of the geniohyoid and the genioglossus. So whenever you're kind of plating the mandible for your mandibulotomies, for your segmentals, for your this trauma cases, so whenever you're plating the mandible, you need to keep one thing in mind. The point of telling this point was that whenever you're plating the mandible in the anterior region, you should put two plates. Because of the talking forces, even if you put one plate, it will rotate around. So you need to put two plates if you're plating in this region. Whereas in the other areas, you can put just one plate, it will suffice. Again, in the condylar region, because of the lateral pterygoid muscle action, there is again a talking and a rotational force here. So you need to put, again, two plates here. Or a three-dimensional triangular plate also comes. So you could treat mandibular fractures by closed reduction, or you could do them by open reduction tonal fixation. Yeah, this is just briefly giving you the cases. The first case, again, parasymphyseal fracture, which we reduced using two plates. This is open reduction tonal fixation. Again, this is a condylar fracture. You can see here the condylar fracture. However, it was just a unilateral condylar fracture, which was still attached to the ramal region, and it wasn't very much dislocated. So we did only a closed reduction and we could achieve a perfect occlusion here. Now the mainstay of reducing a fracture and the mainstay of operating on any of the jaws is to achieve ideal occlusion if the patient is dentate. So occlusion is the ultimate key which people do not pay heed to, which we almost tend to ignore, including myself. So occlusion is one of the most important things. Next we come to orthognathic surgery. I don't know if a lot of people would be aware of this. Orthognathic surgery is basically the surgery to move the jaws. You can move the maxilla, the mandible, or just the chin. So orthognathic surgery is basically done for, when one of the jaws is very much prognathic and the other is retrognathic. When supposing the mandible is too far ahead or mandible is too far back, and the maxilla, or vice versa with the maxilla. So to correct all those things, just dental correction will not suffice. So you need to address the bones to kind of assure that you reach again the proper occlusion and the proper functionality and the proper aesthetics as well. So orthognathic surgery, now there will be, in nowadays, certain ladies also, young ladies would complain that we have a very box-shaped face. So facial feminization surgery again falls under orthognathic surgery, where you can give an osteotomy in the angle region or just reshape it by shaving the angle region of the mandible. This, you can see the total difference in the personality of the patient. This was done 3 weeks back. He had a skeletal class 3 malocclusion, wherein the mandible was way far ahead of the maxilla. So what we did was we kind of moved the maxilla in front and moved the mandible back. So this is what all you can do with the mandible. This would suffice my topic, mandible. So when you move the mandible back, the entire change in the personality comes. This is, of course, cosmetics, but when it comes to functionality, again, it is very important. This is when this is the occlusion initially, and this is the occlusion post-operatively. We all have an occlusion like this, which is normal. That's why you can bite properly, that's why you can chew properly, that's why you can eat properly. Then we have pathologies of the mandible, again applied aspects. which are benign, which are cysts and tumors. The most common could be this destruction of the cortex, could be unicystic ameloblastoma, could be a huge cyst. So again, pathologies of the mandible, you can approach endoscopically, or you can approach by open methods. A young patient, you do not want to kind of do it open method first, so you probably try to do it endoscopically. If there's a recurrence, or if it comes on later on, or if it's an older patient, you probably try to do it like that, in the open method. My presentation is very short, but this is not working. Yeah, so then finally we have one of my favorite topics, onco. So then mandible, another important aspect is for mandibulotomies. Now yet again, in this case, if mandibulotomy is done, when we close the mandible, we have to put 2 plates for posterior axis of the tumor. And mandibulectomies, the various types of mandibulectomies could be marginal, we're just removing one part of it. Could be reverse marginal, wherein you're removing the lower end of the mandible. Could be, this is for the oncological clearance. Then could be segmental, wherein you're removing one segment of the mandible. And finally, it could be hemimandibulectomy. Now, it means with disarticulation or without disarticulation. With disarticulation means when you're doing a hemimandibulectomy and removing the condyle. So you remove the thing in toto. However, if you leave the condyle in place and you remove the mandible from the central till this subsigmoid region, that is hemimandibulectomy without disarticulation. You are not removing the craniomandibular articulation, which is the ideal term given for temporomandibular joint. Last slide. So this, again, marginal. This is hemi without disarticulation, because here would be the condyle, it is still attached. Thank you.
Very well. Yes, very well presented anatomy. I would like to ask a question.
Yes, ma'am. Yes, ma'am.
Patient comes with recurrent dislocation of the TM joint.
Yes, ma'am.
How do we manage?
Ma'am, recurrent dislocation, ma'am, could be, you need to check about the muscle activity first. You need to check about, you'll get certain investigations done. And, you could put the patient on intermaxillary fixation for a while. You put the patient on IMF, and then you see whether it's, what is,